well, tomorrow we'll do your review. Had a few people come up to me. If you're having any issues after the review, I'll be here the rest of the week, so just come find me. If you want to stop by my office, I'm right over next to the senior classroom, the SSRs and all that stuff, and the hallway straight ahead. So COPD, this will be one of the big ones that you're going to see on your test, and we'll see a decent amount of it in clinic as well too, especially in phase 2. So there's the overview of stuff we'll be discussing. All right, third leading cause of death worldwide. It always bounces. It's in the top 5. It may not be third, right, for 2025, but it's in the top 5 for sure. The two main COPDs we're going to talk about is chronic bronchitis, emphysema. There will be a third one at the bottom. It's alpha 1. We'll talk about later in the lecture. That's kind of like not your zebra, but it's the least common of the causes for COPD. But the main two are going to be chronic bronchitis and emphysema. So, chronic bronchitis. Excessive secretion of bronchial mucus. What did we talk about with asthma? What are the two main things that clinical findings we're going to see in that one?
Narrowing
Hyperresponsiveness, right? So narrowly or airway constriction and increased mucus production too, right? So obstructive. So how you're going to diagnose this is daily productive cough times 3 months and 2+ years. That's going to be a key feature. So for that diagnosis, you need at least 3 months of daily productive cough into 2 years, over 2 years. Emphysema, the way you're going to see a lot of this is these overlap, and chronic bronchitis is kind of like the early finding of this, and then it's going to progress into COPD. That doesn't mean they lose that chronic bronchitis necessarily, but the long term is going to evolve into emphysema. The difference between that is permanent enlargement and wall destruction of air spaces, alveoli, distal terminals. So talked about like their pulmonary function testing, how their lungs are very big and kind of floppy. They don't have that last oil anymore, so they can't be able to exhale off the gas. Most common cause, cigarette smoking, 80 to 90% of that, right? That's going to be your predominant feature in that. Why that matters is this alpha-1 antitrypsin deficiency. We'll talk more about that, but there's no smoking necessarily involved with that diagnosis. That's a genetic disorder. What was another disorder that we talked about last week that mimics COPD, or you may think it on initial findings? Cystic fibrosis is like pediatrics. It has similar findings. What was another one? That's more of like closer to asthma, but for COPD, bronchiectasis. Remember that permanent destruction or widening of the airway, right, with increased mucus production. That may be for your differential diagnosis. This we'll talk more about how that kind of plays into this and how you can differentiate it. But remember out of this that chronic productive cough, that's 3 months to 2+ years. These can overlap. They can have chronic bronchitis and emphysema, and then smoking is your most common cause. So pathology of smoking. Bronchi and bronchioles are the most commonly affected, right? The smoke hits it. What does it do? It destroys the cilia, increases mucus production, so that's why you're going to see those chronic bronchitis. They're constantly coughing and sputum production, because part of the smoking is what's doing that. And then fibrosis of the airway, right? So increases luminary diameter, easier to obstruct, right? The more they smoke, it destroys that cilia, they can't get mucus up. They get frequent infections. Those neutrophils come in there, cause more inflammation, and it's kind of like this vicious cycle that feeds into itself. So smoking is doing damage, frequent infections, because now they're more prone to infections, because while they increase mucus, bacteria is hiding in there, which further worsens and causes inflammation, further damages the airway and kind of progresses. So in the lung tissue, the alveoli, this is where we start looking into emphysema. So chronic bronchitis is going to be the bronchi and bronchioles. Once it evolves into emphysema, we're talking about the alveoli, the actual lung tissue. Causes that destruction, enlargement, and then that air trapping, right? So if you put all this together, what kind of chest x-ray would we expect like an emphysema patient if they're having air trapping? What would that do? Barotrauma, it increases the size of their lungs. Yeah, so would they have like widening on their chest x-ray? Actually, yeah. And again, we talked about that neutrophil. A hallmark portion of COPD is the frequent infections. That's one of the features when we talk about severity and how we grade that. It's going to be based off of their exacerbations and everything else. So you don't have to remember this, but it's a good indicator of why you tell people to quit smoking. Reality is it's never too late. It's hard to convince like a 75-year-old who's been smoking since they were 15 to give it up. But you can look right here. So we talked about FEV1, right? So what is FEV1? Yeah, so we talked about the pulmonary function test. FEV1 is that forced respiratory volume of 1 second. So in 1 second time, how much volume can they forcefully exhale? Take a deep breath in, blow out as hard as you can, and that first second is what we're measuring. That's also what we use to determine the severity of COPD and asthma. So if we look at our FEV here on the y-axis and then age on the x-axis, start up here, never smoked, you're going to see a decrease in FEV1 over time, right? Just like any other feature, as we get older, stuff goes down. Testosterone, right? Slowly going to go down. If it abruptly drops, we're concerned. Same thing here. You're gradually over time, it's going to drop. What you're seeing right here is a regular smoker who never quit, and their FEV just keeps dropping. Now, if they stopped at 45, they're actually going to regain some of that function. Not necessarily gain, but they're not going to lose anymore. It's going to start to do that gradual decrease that we see. Stopped at 65, they're still going to have some return of that FEV. So it's never too late to get your patient to quit smoking and salvage some of that lung function. Signs and symptoms. So 40 to 50 years old, right? This is that patient that has a history of smoking, and this stuff is progressively worse. It may be that, hey, I've been having coughing. I get it every winter time. I get an infection, and I cough for about 2 months. It doesn't clear. This has been happening 2 or 3 years in a row. Could that meet that diagnosis of chronic bronchitis? Yeah, right? First, the shortness of breath, increasing cough, sputum production, right? If you remember that bronchiectasis, very similar findings too, right? Periodic exacerbations, the hallmark. They're going to get some type of infection. Something's going to happen. They're going to get exacerbation of this. It's going to worsen their symptoms. And exacerbation, just think baseline. So it hasn't worsened over baseline. Cough, dyspnea, sputum production, inability to do things. As COPD progresses, we'll talk about why chronic bronchitis leads into emphysema. But this is where you start to see emphysema. About that, there's less cough, less sputum, because now they're just working to breathe. Their cilia are destroyed, they can't move air. And dyspnea becomes increasingly predominant. So here, 2 or 3 slides, you're going to see like a picture that describes these. But think blue bloater, chronic bronchitis. If you can, this is what that picture looks like, what we're going to talk about. But if you can kind of imagine these patients in your head, it'll help you out a lot of these tests. So blue bloaters, due to mild hypoxemia and cyanosis, right? So this is that early on sign. They're a smoker. Maybe they have like a slight blue tint. They just look cyanotic. And necessarily be like blue, but they're going to look like they're not getting oxygen. Heavy chronic cough, sputum, daily cough for 3 months times 2 years. Again, that's key for the diagnosis. Diagnosis, dyspnea with exertion or coughing fit. So that patient gets into that coughing fit where they just can't catch the breath. They cough and cough and cough, sputum, and it just keeps going. And that leads to that diagnosis. Wheeze and rhonchi. So that rhonchi, they hear that initially, and then they cough, clear that secretion, and the rhonchi goes away. Mild prairie, right heart congestion. Sorry. So that coughing is constantly putting pressure on the pulmonary vasculature, which makes it hard for the blood to flow through there, which leads to pressure backing up, that pulmonary hypertension, which means the blood is backing up into the right side of the heart, cor pulmonale. They'll get that later on. Lung infections, again, common 1 or more a year. You're going to need to know that for the test is how many exacerbations they're having a year when you're determining their severity and what treatment they need. It's all based off of exacerbations. And then typically with chronic bronchitis, they're overweight because they are dependent, they can't move around a lot, they don't have a lot of energy levels, so they become obese from being a sedentary lifestyle. Now, if you think about chronic bronchitis is that early onset, right? That's beginning, and then it progresses in emphysema. You're still going to have clinical features of both, especially early on emphysema. But this is pink puffers, right? Again, kind of see this picture, put that together. Shallow, rapid hyperventilation, right? So they're constantly trying to catch the breath, but their distal alveoli, those distal airways are destroyed and they're enlarged, so they're air trapping. They don't have that elastic anymore in their lungs, so they can't breathe out properly, so they're constantly taking short, shallow breaths, trying to catch their breath. Now, all that being said, what do we think, like, what's going to be going on with their ABG right now based off their breathing pattern? What's that? Respiratory acidosis, right? So we talked about those ABGs, kind of go down the flow chart. What makes it acidotic or alkalotic? pH. So if it's acidic, is it below or above 7.35? Below, right? So what does respiratory do to that pH? So respiratory opposite, metabolic equal, right? So respiratory opposite meaning what's going to drive that pH? Is that CO2, right? So if they can't blow off that CO2, what's that going to do to their pH? It's going to drop it because the CO2 keeps going, right? So respiratory opposite, CO2 goes up, pH goes down. So these are going to be respiratory acidosis patients. Prominent feature of this is going to be dyspnea no matter what they're doing, even at rest. This is that patient who is on a nasal cannula. They can't take full breaths. They can't have like full sentences with you. They're constantly, they move around in their chair and they're short of breath. Rare cough. Now their alveoli and their cilia are completely destroyed. The cilia are, so they can't move the secretion. So they're kind of decreasing in there, or I mean, kind of consolidating in the lungs because they can't get the mucus out. And then thin patients with weight loss, so their metabolic is out the roof. They're just burning calories, trying to stay alive and trying to breathe. So they're going to be very thin, but they're going to have that AP. So we talked about increased AP diameter. So it's the anterior to posterior. See that guy on the left? This is a normal, right? It's wider than it is deep. And the guy on the right, as he gets that hyperinflation in the lungs, it's going to start to slowly change that. So they're going to have that barrel chest. If they're super thin and advanced in emphysema, you may not really notice that as well because they're just very, a lot of muscle wasting disorder going on with them. It's like pink flakes right here from respiratory effort, right? So they're just, again, they're burning calories, trying to stay alive, they're breathing a lot, huffing and puffing, trying to get air in. And then posturing. Again, they may be sitting in an upright position or tripod, that's sniffing, trying to get comfortable, trying to find a way to breathe. Right. So this is a good chart just to kind of generalize those patients and differentiate between a blue bloater and a pink puffer. A blue bloater is going to have cyanosis due to hypoxemia. They're never really in respiratory distress until they have a coughing fit. At rest, they're just kind of mildly hypoxic. Obesity and edema, and right heart failure, they don't have a lot of energy. They are sedentary lifestyles because if they do anything, they start coughing worse and they're more prone to infections, so they don't go out and do stuff. And initially, they're going to have the high hemoglobin due to hypoxemia. Their body's going to kick in, release more EPO to increase the number of RBCs to meet that demand. But they continue to smoke and it continues to go down. Now, the emphysema, that rubric is that pinkish, that reddish hue to their skin. Right here, anybody ever heard this term? Yep. So that's a wasting disorder. You're going to see that commonly in like cancer patients, some heart failure, aged patients, kind of like that classic finding that they start burning muscle and fat for their metabolic purposes, and they get into this wasting condition where even if you increase their diet, it's not really going to improve it. So patients kind of just keep getting smaller and smaller and shrinking in front of you. Chest X-ray is not required for this diagnosis, but it's good because you may be able to rule out things. So the bronchiectasis, the widening of the airways, you remember what clinical findings we would find on chest X-ray? Signet rings or tram tracks, right? Because that's fibrosis and destruction of the actual bronchioles. So for that diagnosis, bronchiectasis, the diagnosis is made by a CT, right? That's the standard. COPD, we're going to use PFTs as our standard. Chronic bronchitis, you may just see some incidental findings. You'll probably see some more if they're having exacerbation because they have some type of infection. But typically, they're not going to be all that significant or really remarkable. Emphysema, though, I'll show you some x-rays here in a second. That's a very distinct chest x-ray findings that may help support your diagnosis. What you're going to see is hyperinflation and flattening of the diaphragm because they're air trapping, the lungs are getting bigger. So what is that going to do to their total lung capacity on a PFT? It's going to increase it, right? So that may be another feature that you see when you do their PFTs. And cardiac silhouette appears smaller just because their chest has gotten bigger. Early on, it may not mean that they're having any type of cardiac issues. It's just a node finding because their lungs are bigger, increased AP diameter. So left is normal chest x-ray, then the right is COPD. So see right here, the diaphragm, nice and curved. Here, especially on this one right here, on the very right, how it's flattened out. Their chest is significantly bigger. You're going to see less vasculature as well too, because those lungs are not doing all that well. So we already talked about their ABGs, right? So if you're reading an interpreted ABG, try to correlate that with the patient and kind of think about what their respiratory pattern is doing, right? If somebody is on a heroin overdose, are they breathing fast or breathing slow? So if you breathe slow, what's going to happen to your CO2? It's going to increase, right? Because you're not blowing off CO2, and then what's that going to do to their pH? Yeah. So now the exact opposite. Patients anxious and they have uncontrollable or cocaine, whatever you want to think, they're breathing really fast. What's that going to do to their CO2? It's going to blow it off, and what's that going to do to their pH? Increases. So now it's respiratory. All right, there you go, putting together. So just think about that when you're looking at ABGs, the clinical presentation. Inertial early on, that chronic bronchitis is going to be an early finding of COPD. They're going to compensate. Their metabolic is going to do what it needs to do to balance that pH. With emphysema, now they're kind of circling. With these patients too, especially emphysema, they're not going to be just pulmonary, right? What else is going to be happening? It's going to be affecting their heart, so they're going to be under cardiology's care. They're probably going to be under dietitian. These people aren't living the healthiest lifestyle. I would say half my COPD patients were also raging alcoholics over the years. So they were in liver failure as well too. These are usually very sick patients with a lot of comorbidities. So failing compensation, the metabolic can't meet the demand anymore, so now you're starting to see that where it's not compensated. Sputum analysis, this is not like a standard baseline, but patient keeps getting admitted to the hospital. What happens is the more you give antibiotics, you develop a resistance, right? So now you have to start digging into your bag of goodies and start finding different antibiotics that are going to work for these. And the more hospitalizations, what happens the longer you stay in a hospital? Yeah, you're going to get sicker if you stay in a hospital, right? You're going to get nosocomial infections, get exposed stuff. So in that case, then that's where we're going to do a quality or a sputum sample right here. Why would that be difficult in an emphysema patient? Yeah, they have decreased mucus production now. They can't clear it because they have no cilia. So it's spending 10, 20 minutes trying to coax this patient into coughing to get a sample. So chronic bronchitis is very easy. Emphysema is going to be more difficult. And then that ECG, EKG, right? Chronic pulmonary hypertension, core pulmonal. So the more they cough, the more pressure that's putting on that vasculature in their lungs. The more infections they get, that starts releasing inflammatory markers and starts affecting the lungs. You start seeing the heart or the lungs causing vasoconstriction from hypoxia to try to divert that blood to the healthier aspects of the lung, which then again puts more pressure on the heart. And you start to see that build up as well too, and they start getting right heart failure. There's another chart to kind of differentiate the two, right? So we, in bold are the kind of the big things to look out for. Dyspnea, the chronic bronchitis, they're really never in respiratory distress. At rest, it's when they get in a coughing fit and they start having exacerbation that they get dyspnea. The emphysema, they're always short of breath, or always having difficulty breathing. That cough, again, chronic bronchitis is diagnostic because you got to have a heavy productive cough for 3 months over 2 years. Versus emphysema, they can't cough. And then that sputum goes in that as well too. Chronic bronchitis, copious sputum when they're coughing. Emphysema, they're not able to do that anymore because the airways are destroyed. So kind of putting that together, you're going to have that chart on there on how to diagnose these, or the PFTs. So decreased FEV1, decreased FEV1 ratio, 0.7, that's going to be diagnostic, right? And then how would we differentiate COPD versus asthma on a PFT? The reversibility test, right? So we do standard baseline PFT, then we give them bronchodilator, albuterol, and then what are we looking for that? What's the change? 12%. Yeah, 12% change of FEV1 and 0.2 liter change, right? So FEV1 is good for severity in COPD and asthma. And also, do you guys see this right here? What does that look like? Scoop, right? Scoop is meaning obstructive. This could also be restrictive as well too. It's peaked right there. It's a smaller amount. So it could be a mix on this one on the right. So here's the staging. You'll have this chart again on that thing. So when you get these, this is literally what I'm going to give you during the test is this sheet right here. That chart that we've gone over. So you're going to have this portion right here, the gold, is the same thing that's on here as well too for COPD. Okay. So we determine our severity. We don't use it for actual treatment guidelines. We'll go over those here in a second. But it is beneficial to kind of help your patient. Patients want something. They want to know how they're doing. Is it recovering? Is it improving? This is a quick and easy way to go over that. And that'll also determine maybe they need more routine PFTs. They need advanced imaging if their FEV keeps going down. So mild FEV1, greater than 80% predicted, and then you guys can follow it. All right, so up here at the top, we have a PFT. This is kind of a check on learning. You're going to have this chart on your test. So the very first thing we look at is what on this? FEVC is going to be for what? What kind of disorder? Restrictive, right? So if we go to here, the top right of our chart, is that FEC decreased? This is the predicted, right? 3.23 based off those factors that we put in there. So age, sex, height, lower limits of normal. And this is what the patient actually did. So is it decreased? Yeah, it's 90%. To make the diagnosis, FEC decreased, lower limits normal. Is it lower limits of normal? So is this restrictive? No. So now we're going to see, is it obstructive? Look at FEV. Is that decreased? But that's not our diagnosis, right? We need FEV1, FEC to determine if it's obstructive. So is that decreased? Yes. 58%, right? So what do we need the diagnosis to be for COPD? Yeah, let's go to our little chart right here. It says 0.7 or 70% of predicted, right? But we're not sure if it's asthma or COPD, right? So what do we need to do? Cool, reversibility. So post-bronchodilator, right? So what are we looking for in FEV1 to see if it's reversible? 12%, right? Is that 12%? No. It's 8%, right? So are we comfortable saying this is COPD? Cool, because it's not reversible. Now gold staging, we look at FEV1, which is down here, the actual gold one. What gold stage are they in? Their FEV1 is 53%. Actually, we're looking at post-bronchodilator, so we're going to look right here. 57, so where would that be? Stage 2 moderate. Cool. Now, is this chronic bronchitis or emphysema? How can we determine that? What's that?
Was that a DLCO thing?
DLCO is like a further test for the diffusion capacity, but we can look at this chart right here and determine if it's emphysema or chronic bronchitis. It's by the TLC. Total lung capacity. Remember, they have air trapping, so their lungs are getting bigger. So total lung capacity should go up with emphysema. So is their TLC increase?
Yes.
All right, so is this chronic bronchitis or emphysema? Emphysema, right? And then what kind of chest x-ray or CT findings will we find on chest x-ray of chronic or with emphysema?
Barrel chest.
What's that?
Barrel chest.
Barrel chest like clinical finding, but on chest x-ray, flat diaphragm, hyperinflation, and then that flattened or that widened chest and large lungs, what's that going to do to the heart diameter comparison? Yeah, it's going to decrease it, so they're going to have a smaller appearing heart on the chest x-ray. All right, so getting into meds management, you guys have seen this numerous times. We talked about it in asthma, and you got your pulmonary class or your pharmacy classes. So our SABAs, all right, or bronchodilators in general, they're going to improve symptoms, quality of life, but they're not going to do anything to actually change the patient's outcome, right? The hope is if you improve their symptoms, they can actually quit smoking and live a healthier lifestyle. But as far as underlying disease, it's not going to change that. So our SABAs, are short-acting beta agonists. We've talked about this. Rapid heart rate because it's going to affect the heart, shakiness. Often combined with SAMA, so Combivent or Duonev is a common thing. Like Duonev would be something you'd order in the ER, ICU. Combivent would be something you prescribe for outpatient. And then LABA, so long-acting. What do we talk about? Can we ever give a LABA for asthma patient by itself? Why? Yeah, mask their symptoms, so it'll help with symptoms, but it's not doing anything for the actual inflammation of the airway. So black box warning in asthma to give a LABA, but it's acceptable in a COPD patient because they don't have the same inflammatory hyperresponsiveness that asthma would have. Additional meds is anticholinergics, SAMA and LAMA, right? The drying agents that helps with the mucus production, so you can add those as well. For testing purposes, I'll clarify tomorrow, but they're going to be the questions or the answers will be, is it a LABA? Is it a SAMA that's appropriate? There's not going to be necessarily trade names or generic names. I want you to focus more on the class of medications because it depends on where you're going to be working, what medications you have available. So as long as you know the class, you can talk to the pharmacist and say, hey, I see you don't have Symbicort. What's a similar medication that you have appropriate, right? So if you're smart when you get to like your clinical sites or your phase 2, you become best friends with the pharmacist and steal their great ideas and then pass it on to the patient like you're a genius. Oral steroids or inhaled corticosteroids, we don't necessarily give that for mild COPD unless it's indicated by exacerbations or things are worsening. And a big difference between asthma and COPD, they overlap, but our treatments are going to be different, right? So we already talked about no LABA by itself in an asthma patient, but it's okay in COPD. Oral steroids, we talked about if they have an asthma exacerbation, we give them a 5-day course. For COPD, we're going to do a 14-day course when we discharge them. And some of our emphysema patients, long-term, may be on a chronic oral steroid. Typically, that's going to be managed by pulmonary at that point. That shouldn't be, if they're requiring that in your primary care, and you're doing that on your own, you're wrong. They should have been consulted or referred for expert care by that point. And antibiotics are frequently due because the key hallmark of COPD is what? Infections, right? Hospitalizations. They're going to get at least one infection, typically a year. Right, so you don't need to know this. This is what the old guidelines for gold are going through. And all these guidelines are free open source. You can also find them on UpToDate. It's another great resource. This chart at first looks a little like goofy. You're not going to have this on the test, but there's not that much to memorize. So you look down here, group A, B, and then E. If you get a question and they say, hey, the patient's had one exacerbation in the past year, and they're having these symptoms, do I even need to go over here? It's not going to be group E if it's one exacerbation or less. It's going to be group A or B, right? So read the test question when it talks to you about how many exacerbations, hospitalizations that they're having, and that's how you're going to correlate this chart. So if it's 2 or more, it doesn't matter what their symptoms are, you're automatically going to go to group B, which is going to be that long-acting beta agonist, that long-acting muscarinic agent, and then if you have a CBC and their eosinophils are greater than 300, you're going to add an inhaled corticosteroid. Okay? So again, if you get a test question or they say, hey, they've had 2 or more hospitalizations in the past year or exacerbations, you're going to go straight to here, right? They've had 1 exacerbation, no hospitalizations, we're going to come down, it's going to be group A or B. The difference between that is going to be their symptoms. So on the left, you have an otherwise healthy patient, group A. They get dyspnea when they're doing strenuous stuff, versus group B, where they get dyspnea just doing normal activities. Right, so key to understand, those are the 3 main groups for this test. 2 or more exacerbations, they need COPD, hospitalization, they automatically go to group B. It's going to be those meds. Versus if they've had no hospitalizations, then you just have to differentiate it based off their symptoms. So we talked about this briefly. COPD exacerbation is anything past baseline, right? So if before, like, hey, I could go up my stairs at my house, I could play with my kids or my grandkids, I had just a regular cough and sputum production, all of a sudden they said, hey, over the past few weeks it's significantly worse, or hey, I can't catch my breath no matter what I do. Before I would just sit down for a few minutes and it would go away, but now I'm just having it. We consider that exacerbation. And almost all of them are going to be some type of infection when they have these exacerbations. So think flu, wintertime, cold symptoms. People are stuck indoors, they're exposed to this stuff. Think some type of infection. Other triggers. I had a COPD patient who went on vacation to Eastern Europe where everybody smokes, came back, significantly worse, and we had to hospitalize him. Got an infection over there. He was exposed to a lot of secondhand smoke. Now they're starting to get into heart failure because of all that increased pulmonary hypertension. That may push them into having exacerbations. Then again, remember I talked about sick people get sick, right? That patient gets sicker in the hospital, we don't just think, oh, well, necessarily, hey, their COPD is just getting worse, we need management. You may be missing something else, that pulmonary embolism, because now they're stuck in a bed, maybe on some medication that reduces their hypercoagulability. You may be missing something. Treatment of exacerbations. You can add a SAPA if they don't already have one on. Antibiotics, steroids, 5 days for asthma, 14 days COPD. What about oxygen on these patients? Guy comes in and his SATs are like 92, 93. Do we need to put oxygen on him? What's that? Yeah, that may be normal for him. So if my CO2 goes up, what does my body, for a healthy person, start doing? Yeah, it compensates, right? Your body's saying, hey, the CO2 is higher than what we need. We need to blow it off, so I need to increase respiratory rate or respiratory depth, like the depth of my breath, so I need to blow off the CO2. COPD patients are living at that baseline, right? So their we already talked about their respiratory acidosis. They're just living with high CO2. So what is telling them to breathe at that point, because their body's not responding to CO2 anymore? Their kind of brain has changed, so now they're focused on hypoxia, right? So their body's saying, hey, if you're hypoxic, you need to breathe more, because we've grown so accustomed to the CO2, our body's adjusted, so we're not responding to it anymore. So if I go ahead and put that dude on a non-rebreather at like 10 liters, and I get his oxygen saturation up, what is his body gonna not do? It's not gonna breathe, right? Because hypoxia has now become the trigger for that patient to breathe because their CO2 is so high. So you have to be careful with COPD patients and oxygen. You don't wanna crank them up. Most of the time, 92% or above is what we're fine with. So if they need a nasal cannula, like 1 to 2 liters to supplement, that's fine. But we don't want to go like full ham and just crank up the oxygen and not let their hypoxic drive. Not helpful cough suppressants. Why would we want to give cough suppressants or not give it? Yeah, they need to clear the secretions, right? We don't want to mask that because chronic bronchitis creates mucus production, cough. They need to clear the secretions. All right, so there's a lot to remember on here. The easier way to break this chart down as far as antibiotics, I'm less worried and concerned about pathogens, right, for testing purposes. But if you understand their exacerbations, then that'll correlate with what therapy you're going to give, right? So uncomplicated, right? We're going to go over here. We're going to go with those common medications. So if you have a test question, look at the patient characteristics. Is it complicated or uncomplicated? And then that's going to determine what antibiotics you're going to give, right? Anytime they spend more time in the hospital, they're more prone to the nosocomial infection and those kind of different bugs that we're going to get in the hospital, and that's what's going to change it. Typically, if they're hospitalized, they're going to get some type of IV antibiotic, right? And it's going to be a more severe infection. All right, so this is that least common. I mean, I wouldn't call it a zebra, but this is going to be that patient that is 20 to 30 years old, no history of smoking, they've never lived in there, nobody in their family smokes, they've never been exposed to secondhand smoke, and then they're developing COPD-like symptoms. And that is that A1 antitrypsin deficiency. You may see it called AAT, you may see it called AATD. If you heard about this disease or this deficiency in the other classes, you guys started GI. All right, so they may talk about this in GI as well because this is going to affect the two primary organs. It's going to be the liver and the lungs. What this does basically, antitrypsin is going to block some of those immune inflammatory cells, but without it, now when they get neutrophils increasing in there, you get all those inflammatory markers from that. That's going to affect your lungs. If they smoke on top of this, you're likely going to see emphysema a lot quicker in life. Versus their 20, 30, you may see it in their teens if they're smokers. Late teens, early 20s, when they're younger, their body compensates until they get older, and now they can't really compensate anymore, and then they have emphysema-like findings. No cure, they do lifelong supplemental antitrypsin 1 meds that'll help slow the process. Big thing is you want to make sure patients aren't smoking. They're getting their vaccines and living the healthiest lifestyle they can to avoid those triggers or anything that's going to push them over the edge. Differential diagnosis, we talked about this. Asthma, you differentiate by that reversibility test, right? You get a PFT, it's obstructive. You give a bronchodilator, FEV1 increases or improved by 12% or more, and you get 0.2 liters or more, then we're going to call it asthma and not COPD. Cystic fibrosis, typically with the differentiation between that and COPD, very, very unlikely that somebody's been walking around for 40, 50 years with cystic fibrosis not knowing it, and then all of a sudden they just present one day. Typically that's going to be their history based off that. Not uncommon, or I mean it's not impossible, but it's very unlikely. The alpha-1 antitrypsin deficiency, like I said, think about, you get a patient who's 25 years old, no history of smoking, but now they're having a chronic cough with sputum production. You get a chest x-ray, you start finding these other findings, hyperinflation, that it's prolonged. We talked about that bronchiectasis, it's not up here, but think about that one too. It's an differential diagnosis, it's going to present very similar, but the diagnosis for that is going to be a CT because you're going to see that fibrosis of the bronchioles, the bronchi. Complications of COPD, pulmonary hypertension, right? So the vasculature is vasoconstricted because they're hypoxic. They have frequent infections, which leads to those inflammatory markers, which further damages and remodeling of the airway. Again, it's just good common sense medicine. Stop smoking, get your vaccinations, take your medications as prescribed. When to refer. So if they have it before age 40, what are we thinking? What's that? A1 antitrypsin, right? Now, if they started smoking when they're 12 years old, and they're 40 now, 38, I mean, it's not uncommon, right? Greater than 2 exacerbations per year are already maximum treatment at Group B, which was any hospitalization or 2 more exacerbations, they should be Group B for medication management. Very rapidly progressing disease, resting O2 saturation below 90%, right? So typically these people are resting in the low 90s. So if they start getting to below 90%, then we have to be concerned. Then when to admit, so unable to maintain O2 sats above 90%, and you may see that with somebody who's already on nasal cannula, and they're already maxing it out at like 3 or 4 liters, and they can't maintain it, we have to get them in the hospital. Hypercapnia, that'll make more, we're gonna talk more about hypercapnia in the next lecture too, OSA and Pickwind syndrome. But if their CO2 is rising, that means they're not controlling it. They no longer have that respiratory drive to actually control CO2. Change in mental status, that may be a finding that you're gonna see that, hey man, they're kind of at this baseline of 90 and 92% at all times, but now the differentiation is they can't really communicate clearly with you. They don't know what's going on. Are they a reliable historian at this point? You talk to their family member, their caretaker, their home nurse, the nursing facility to say, hey, is this baseline or is it not? The ability to sleep or care for self, high-risk comorbid conditions. These patients, emphysema, are typically, like I said, they're never going to be just that. It's going to be heart failure, it's going to be nutrition deficiencies, it's going to be some type of liver issue going on. It's likely they have hypertension, it's likely they have diabetes, hyperlipidemia, they're just a train wreck. All right, blood transportation or transplantation, very uncommon in COPD patients. I worked with a pulmonary salvage team at one point in Germany. We got a few lung transplants for younger patients with the A1 antitrypsin disorder so that they could have longer life. So it's very unlikely you're going to get a lung transplant for a 70-year-old who's still smoking. They're just not going to make the cutoff. And then more likely, if they're having all these things, they're not going to survive the surgery. Most likely, no surgeon's going to give them a lung transplant. One thing they will do that is not super common, but it's not uncommon, is lung volume reduction. So basically, once they get to emphysema, they're hyperinflating, they can't use it. Some of those lower lobes, they may reduce them so they don't get that barrel trauma, and it takes less pressure, takes the pressure off their heart, because now their chest is less filled, and they're putting less restriction on the heart. Any questions about COPD? Yeah.
For the anti one, that'll put along your line, but that won't change the
Yeah, so they have some medication, but it's still not 100%. That you're still going to see slow progression to that, even with medication management for the A1 antitrypsin disorder.
Can you still serve with that?
Is that?
They find out that you have that after you've been in the Army or whatever.
So the weird thing about, like, as far as retention in the Army, the Army PAs, you're going to get to know this document better than any other document you've ever known. It's AR 40-501, Standards of Medical Fitness. It's going to be your Bible for everything. It's going to be schools, physicals, it's going to be retention, all that other stuff. Asthma, per DOD, you can't stay in. You get a med board, they may find you fit for duty, but you're never likely going to deploy or do anything. And typically that's only going to be if you have a very useful skill set that the Army can't easily replace, something like a neurosurgeon or cardiothoracic surgeon. Everybody else can get a med board. So I've never actually seen anybody stay in with that. Most of the time they're discharged. Any other questions? All right, so let's take 10, and then we'll come back and do the last one.
exactly what I said. Like, there's hip hop, and they're sitting there going, like, you know, magnesium. So, I'm just know I'm angry about it. Bullshit. Yeah, it's straight up. They're just going through all this stuff. Yeah, it's just yeah. She wanted to
So, if you're blowing out students,
I didn't know what it looked like.
It's like you're 2 years out of college. I think it's 260. He's making that. I said, base. Sitting in the office, looking at numbers and talking on the phone. I just got tired. He's like, I some excitement in his life. And he said, some fire truck drove by his office. Like, you're in a commercial, look down, two fire trucks. Like,
The hardest thing.
adrenaline and exhilaration.
Those really visible ones that you put them on and they're like,
Just so happens. He knew he wanted to go He did 6 years. He got out. 15 years out.
there's nothing.
Oh yeah. Because it wasn't like every 2 years. I think the wind is just up right now. It was like 45.
No, I wash my hair. I wash my hair at least once a week. If I wash my hair, that's why I don't every day. I have to, because if not, it's not like it's just me. And then it's just like, You don't have the same thing, but it's blue.
It's my favorite part of the day.
Pretty nice, huh?
I want her dog said he'll come back on.
Unless it's
She knows. It was like, straight to me, like right there. And when I felt it, I was like, oh, and she was like, it took a second for her to register. And then I put her back. And she was trying to flick her out in circles. I've tried to have kids take away. Guess what? Good luck. That's my face.
I bring lunch, but he was not staying at lunch. If you want to do it Saturday, that's fine.
Got it, like the bunks, all the carburetors. Oh, yeah. Two clicks to that thing, your Team J.
Scoliosis, you got you.
Have you seen this guy?
Yeah.
1, 2, 3, like what zone?
Oh, the actual chiropractor?
Yeah.
No, I've seen it.
He pops up all the time. He'll push on your head in 6 different areas, like zone 1, zone 2, zone 3, zone 4, zone 5, zone 6. He's like, which one is more? I'm like, zone 2. It's like, oh, that's your elimination zone. He just starts doing the same stuff. It's so stupid.
All right, start sitting down and get ready for the next lecture. Real quick on that last class, when the students pointed out, and they were 100% correct, is down here left side, complicated exacerbations, this should be FEV1 less than 35% predicted. See up here, for complicated exacerbation, it's 50, less than 50, greater than 35%. Down here, this should be less than 35%. Right? Less than 35% FEV1.
Mm.
You guys heard about the burn pit registry? About the VA, right? So I mean, the VA is actually doing the right thing. Every war has its hallmark disease. You know, Vietnam, Agent Orange. GY, it was TBIs, burn pits. So the burn pit registry is done by the VA, and it's basically, if you've ever deployed or been an operational assignment overseas, they have that list of countries. So I tried to order air quality testing when I was deployed multiple times. This is one of those things that drives me crazy about the DoD. Was so Djibouti, I was in Africa, we had an air quality test done because we were the ones burning the trash. Then I go to Uganda, and it was only like 30 of us with SOCAF at a little headquarters there. And all of our neighbors burned trash. I couldn't get SOCAF, SOCUR, Big Army, anybody to pay for it because we weren't burning the trash. So it's one of those frustrations. What's that? Yeah. So you can still document that for your patients. But air quality is a bigger concern, especially we never seem to go to war in nice places, right? One day New Zealand or Ireland, maybe like a temperate would be nice where I don't have to be sweating the entire time or freezing the entire time. All right, so next we're going to be talking about obstructive sleep apnea and obesity hypoventilation. OSA is going to be something you're going to see on a regular basis. Military reflects society. Society's getting fatter. Despite whatever Secretary of Defense says, we are still getting fatter as a DoD too. And that's not a political statement, it's just a reality, right? We can look across the formation, all these beardos with their tabs. Come on, guys. And every patient who's trying to play the game is going to want a sleep study, right? I'll give you one trick how to kind of get out of that here in a little bit. So overview, ventilation versus oxygenation, we've talked about this, kind of beats the graph, right? Ventilation is that volume exchange, and that's how you're going to blow up that CO2. And then oxygenation is how you do the gas exchange for O2, right, at the alveoli level. Apnea, cessation of ventilation, right? If the patient's apneic, they're not breathing. Hypoventilation doesn't necessarily mean respiratory rate, it could be tidal volume, right? Tidal volume is the normal breath volume that we're doing. So either their tidal volume or the respiratory rate is inadequate and it's not meeting the body's demand for blowing off CO2. 4 common causes of hypoventilation. That's going to be key to understand when you make the diagnosis for these two. COPD, already talked about that. Obesity, right? They're too fat, the fat's spreading down their chest, they can't breathe. Opiate medications, anything that's sedating, and it doesn't necessarily just have to be opiates, right? There's other medications. What are some other medications that'll maybe potentially cause that? Is that antihistamine will make them a little sedated, right? Paralytics, right? If I pull a dextra, it's definitely going to cause hypoventilation because now they have no respiratory drive, they can't breathe. It's not just opiates, but that's going to be the most common. Then neuromuscular disorders, ALS, Lou Gehrig's disease, among others. So when I went through school, this was called Pickwinian syndrome. It used to be they always had like a picture of the fat little guy who was short. It's like classic from the 1800s in England. But now we have this fancy term, obesity hypoventilation syndrome. So Obesity being key, right? They have to have a BMI greater than 30 for this diagnosis, which we'll talk about in a second. But it's pretty straightforward. If I have you lay on your back and I put like a 50-pound kettlebell on your chest, are you gonna be able to breathe easier? If I put like a 20-pound kettlebell on your neck, are you gonna be able to breathe easier? Same thing, right? Patients morbidly obese and they come in with knee pain, what's the first thing I'm gonna tell them? Like, no, let's get an MRI and see your ortho. No, it's gonna be, hey man, you need to lose weight. Your knees aren't designed to carry this weight limit. So same thing with your pulmonary system. If I have all this excess weight on the chest, they're not gonna be able to breathe correctly. And we show a restrictive pattern. So remember, obstructive is I'm breathing through a straw, right? Restrictive is I have a band around my chest, so I can't take a deep breath in. It's the same thing. If they're fat, all the fat's putting down on their chest, they're not gonna be able to take a deep breath in. Consider this a subtype of obstructive sleep apnea. You have to have the diagnosis of OSA to make this diagnosis. Signs and symptoms, very similar to sleep apnea. Disordered breathing during sleep, snoring, sleep obstructions. Again, we're going to talk about OSA. They're also going to describe this, right? That non-refreshing sleep. No matter how many hours they sleep, they don't feel like they rested. They're just tired. They feel like crap. They have headaches. All that stuff. They may be hypertension, no matter what medications they take and lifestyle medications they make, their hypertension is not improving. They're always tired during the day, excessive daytime sleepiness. But what's interesting about obesity is it blunts the ventilatory drive. So we talked about CO2. CO2 increases what is our body's natural reaction? Increased respiratory rate or increased respiratory depth, right? The bigger the breath because we want to blow off that COPD. With obese patients like this, it's blunted. So CO2 increases, their body doesn't go into that lizard brain where it starts saying, hey, I need to breathe faster. And the exact opposite, it just says everything's good, CO2 is rising. So at that point, they're only really going to breathe deeper if they become truly hypoxic. And after a while, that may not respond either. But daytime hypoventilation is going to be key to this, right? That's what differentiates the diagnosis between OSA and this. So all of these are required for diagnosis exclusion. So first thing I'm going to do is absence of other disorders that would explain this, right? Is this person a drug addict? Do they have some type of neuromuscular disorder, some type of thing that's causing them not to breathe, right? ALS or something like that. Then a diagnosis of OSA, so they need a sleep study. We'll talk more about that. Obesity, they have to be a BMI over 30. And then daytime hypoventilation. So you're going to get an ABG on them during the day, and that's how you're going to diagnose it, right? CO2 has to be over 45. Respiratory acidosis. So again, it's that obesity is blunting their ventilatory drive. They don't have the same responses that we do. Their CO2 goes up, but their body doesn't kick into overdrive and start breathing faster or deeper. It just kind of keeps doing the same thing, and that CO2 keeps on increasing. Treatment, again, it's weight loss is the number one thing. Patient gets skinnier, they're going to have less of these problems. But think about that patient motivation, right? If they're excessive daytime sleepiness, poor concentration, they just always feel run down, are they going to want to go to Gold's Gym and go get on the treadmill? Right? So these are very difficult patients. We have some new tools nowadays. What are some stuff we could do to help them lose weight? GLP-1, right? It's cure all for everything. They could have a gastric bypass. They could have a number of things. It's hard to convince these patients of what's going on or to get them properly motivated. I'm brutally honest with my patients. I'm like, hey, we don't treat this, you're going to die, right? There's no other way to say that. It's high mortality rates, right? Your body can only be hypoxic and hypercapnic for so long before you start going into some other type of failure. Pulmonary failure, cardiology, cardio failure, a number of things. So this isn't that super common that you're going to see this on a regular basis. Typically by this point, they've already been referred to pulmonology. You just need to keep an eye on it. If you have that patient that is, you put them on CPAP, they have hypertension and they're not getting better, consider this as a diagnosis, right? It just, no matter what you're doing, it's just not improving. They may need to go get pulmonary testing to determine that, hey, that may move them to the front of the list or the line for gastric bypass or some type of things, or if insurance won't approve it for like GLP-1s or anything, make a misdiagnosis and may change their what you can get out of the insurance companies. All right, so OSA, obstructive sleep apnea. So sleep apnea, right? Apnea, it means what? They're not breathing, right? It just means cessation of breathing. Sleep, put it together, right? Are there other types of sleep apnea besides obstructive? Yeah, there's central, which is more, we're not going to cover in here. But understand that there's other types of sleep apnea. So central sleep apnea is where your brain basically stops sending signals to your respiratory system to breathe while it's asleep. It's a lot less common in OSA. OSA is being the vast majority of sleep apneas, but it's another thing that you can look out for. So essentially what happens right here, you see green being good, normal airway, the air is moving through here, and then with obstructive sleep apnea, all that soft tissue in the back of the throat relaxes, and it impedes on there. So I think about it like a flutter valve, right? A truck, we occasionally release it, gas comes out. But with this, their airway is being obstructed, so they're not getting deep breaths or being able to get full breaths, so they constantly wake themselves up. So things that can increase that, so obesity is the number one thing, but you're also going to see, determining on their upper airway, if it's narrow, they have a small jaw, large tongue. What are some type of patients that just automatically are going to have large tongues? Down syndrome, right? Difficult to intubate. They can, they're more prone to obstructive sleep apnea as well. So consider that your patient population. Worse with alcohol, opiates, or sedating meds, right? Patients like, I'm just not getting a good night's sleep, so what do? I'm going to do a little bit of NyQuil, a little tussin, Robotrip, and then it worsens out their symptoms. And typically when they take these meds, their partner or whoever they share a bed with, or their roommate or their tent mate is going to say, dude, last night, man, I couldn't sleep. It was actually on a deployment where I got diagnosed with sleep apnea by the doc on the SORT team, who was a sleep medicine doc. Just one next day, complaining, he said, hey man, you need a sleep study. You definitely have sleep apnea. Diagnosing you. I'm kind of bad about myself, or whatever. So, most common, right? Overweight, middle-aged man. Boom, right here. I'm the guy. OSA, this is me all day, right? So, think about our patient population. If they're nearing retirement, don't withhold sleep study because they get bigger, they get older, they're going to be more prone to it. Loud snoring. So everybody just thinks they snore, they have sleep apnea. You can snore because of a number of things, right? Deviated septums, untreated rhinitis, stuff along those lines. So typically it has loud snoring, but you don't have to be snoring to have the diagnosis of this. You can be a quiet sleeper, do that. But typically loud snoring is trying to catch the breath, and then they have that apneic episode where they stop breathing and they wake up abruptly, kind of clearing their throat. But they're not completely wakening, and that's the frustrating part of the sleep apnea, right? It's this constant, frequent wakening, but not to the point of consciousness. They just kind of disturb it so it's micro as they're going. Again, those symptoms that we talked about, morning sluggishness, chronic headaches, work-related problems, poor judgment, all that stuff. Just like in real life, when you don't get a good night's sleep, the next day you kind of suck at work. You're not really optimal, but this is a chronic condition, so they're like this every day. So Joe may be a poor performer, but it's because he has untreated sleep apnea and he's just not doing that, or they're not compliant with their treatment. So Epworth's sleep scale right here, daytime somnolence. I'll go over this chart here in a second. You don't need to memorize it, but Epworth, sleep apnea, that's the handout we give to our patients to document their how they're feeling during the day. Again, hypertension. So when you think, if you have a patient that's not responding to medications and they're still hypertensive, think sleep apnea. Think about the deep REM of sleep, like all the REMs and the stages of sleep. What is happening when you're sleeping? What's your body doing? It's repairing itself, right? So it's rebuilding, it's flushing out anything that's bad and fixing itself. So if you never get a deep night's sleep, your body's never really recovering. So it makes you more prone to other diseases. There's a significant increased risk of diabetes with OSA, But think about that. If you have a test question, ever patients aren't responding to this, whatever, some additional studies you may want to determine if there's an underlying feature of why they're still hypertensive despite 2 or 3 medications. So this is the Epworth Sleep Scale. So when I have that 19-year-old come to sick call, who's just like, I definitely have OSA. And I was like, dude, your BMI is like 2. Like, what are you talking about? Definitely don't have sleep apnea. They just keep coming back. They go to patient advocacy, blah, blah, blah. So I'm like, all right, here's what we need to do. First appointment, I'll be like, you need to cut out all caffeine, all alcohol, blah, 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 and come back in 30 days, right? This is where you kind of see if they're really, like, truly something going on. If you do that, they come back in 30 days, you're like, all right, you up the scales on me, man. All right, I got something for you. So then I'm gonna say, hey, Epworth Sleep Scale needs to complete this. Do it for 30 days and come back. I mean, if they're truly sick, they're gonna come back. If not, they may say the squeeze is not worth the juice, but you can do that. If they're married, I'll even make them come back. I'm like, oh, your spouse didn't do this either? Oh, they need to do it for 30 days. So I'm not telling you to put barriers up in care, but sometimes you need to kind of educate your patients and determine if it truly is OSA. That's another thing is as far as this is not testable, but as far as readiness, this can significantly impact your formation as well. Too, if you have a bunch of people with CPAP machines, they can't necessarily go to an austere environment without dedicated power. So you try to deploy somebody, if it's too austere, they won't let you send them because now you don't have a dedicated power source and they can't be on their CPAP machine if power goes out in the middle of the night and then they're stuck on a mask, right? So it becomes a health risk factor. All right, so physical exam. What's the number one finding you're going to see in OSA? Yeah, obese. You're going to be mean about it, I guess. If you're obese or fat, if you want to be that guy. So typically it's going to be off their history. You may find some of these physical exam findings, sleepy appearance or falls asleep during clinic visit. I've yet to have a patient fall asleep on the middle of a visit with me because I'm so charming and so entertaining. You may see, if you look in their airway, narrow, shallow oropharynx. I mean, it's good information to have, but are you going to change anything about that? It's going to get a sleep study. That may, if they have a lot of excessive, that may change. Hey, after your sleep study, I don't think you need CPAP. We need you referral to ENT for surgery. Nasal obstruction, if they have a deviated septum or nasal airflow, that may just say, hey, go to ENT, and then let ENT decide if they need a sleep study or not based off of their evaluation. ENT will a lot of times cover or manage sleep apnea as well too. It's a big moneymaker in the civilian world. Some more ENTs are doing sleep studies and management of sleep apnea. Hypertension, again, we kind of beat this down, but right, if they're refractory to standard treatment, I want you to think obstructive sleep apnea, that their body's not recovering, so it's never really repairing itself, and you're constantly tired, and it's constantly causing issues, and it's affecting their hypertension. Party score, you memorize these pictures. Just remember, class 1 is the best. 4. You're going to go more in depth about this in ENT and emergency medicine. Because when you intubate somebody, before you do the intubation, you look at the Party score to see if it's going to be easy or difficult. And then we'll talk about why that matters as far as surgical options for this. Stop bang. Right? There's not going to be a question on the test that says what is the T in stop bang. But if you put all this together, it's going to point you in the direction of sleep apnea, right? Snores loudly, not an absolute requirement, but it's pushing you in the direction of sleep apnea. Tired, daytime fatigue. Now quantify that and talk to your patient. Do they have a newborn at home? Do they have a shitty, stressful job? Are they on way too high of Adderall? Figure those things out. How many cups of coffee a day are they having? Observe apnea. Typically, that's going to be history. It's going to be if it's a single soldier living in the barracks, ask their roommate. If they're in the military, ask their battle buddy or their people that they're sharing a tent with or sharing when they're deployed. Hey, are they having these symptoms? Have you witnessed apneic moments? Pressure, hypertension, right? If they have uncontrolled hypertension or just hypertension, that's going to point me again in the direction of sleep apnea. BMI, it's going to be fat, right? Or bigger. The higher, it's like I said, middle-aged men, it's going to be your prime patient. Neck circumference, right? They look like they have no neck. It's just like traps go into their jawline, right? Put a point in there, and then gender males. So I've seen patients with sleep apnea that were just the most physically fit, like guys who lifted weights because they lifted so much weight, so much muscle, made their neck very big, started having breathing problems because of that. All right, polysomnography, this is your sleep study. So a full sleep study, right, not the take home. Gonna have EEG, EOG, EMG, right? ECG and pulse oximetry. Why would we need EEG? What other type of sleep apneas are there? Central, right? So full sleep study will differentiate there. They can look at, do they have restless leg syndrome that's keeping them awake? Do they have central sleep apnea, something going on with their brain? Or do they have obstructive? Respiratory effort and airflow. Towards apneic episodes, that's going to be a key feature, and O2 saturation for the diagnosis, those two. And is there anything cardiac dysrhythmia is associated with when they go to those hypoxic moments or doing that? Maybe indicating that there's early right heart failure because they're not breathing and they're putting pressure on their lungs and their chest and their heart. The other one we're going to have is home testing. So that's typically a less severe, less sick patient who you have a high probability and you think it's obstructive sleep apnea. So this is going to do nothing for determine or diagnose restless leg syndrome to differentiate with central sleep apnea. It's a take-home study. And all it's given us is those apneic moments and their desaturation events. So this is not typical of what they look like. I ran a sleep clinic for a year and a half at Fort Hood, the most boring job I've ever had in my life. But it did allow me to go to PA school because I was at night watching people sleep and doing classwork, homework. So a few things that when you guys are ordering these, patient says, I don't think I'm going to be able to fall asleep. Can you give them Ambien? So any sedating medications may impact that test and give them a false negative or a false positive. So before you think you're doing the right thing, talk to the sleep medicine clinic and say, hey, is it all right if I prescribe this? Or just tell the patient, hey, there's nothing I can do. They take the test. If they don't actually sleep, which is not that uncommon, there's nothing more creepy than sitting up there for 6 hours in a sleep clinic watching a video screen, the person just staring right back at you for 6 hours. It's really weird. Guys give me the finger and like do sign language. And I was like, yeah, I saw that at 2 in the morning, man. So talk to your sleep medicine ahead of time. If they're unable to sleep, a lot of times what will happen, then sleep medicine will prescribe them something to make it, that'll have less effects on the sleep study, but let them make that decision. All right, so the sleep study, what we really care about, especially for testing purposes, is this AHI, apnea hypopnea index. Now we'll go here together as a sample to show you. So normal AHI is 0.4 to hour, moderate, mild, moderate, severe is AHI over 30 and or O2 saturation less than 90% for greater than 20% of the study, right? So you'll need to know these AHIs for the testing purposes to understand that, right? Then we notice right here, mild, moderate, severe. Mild, they may not even know it, they're just getting a sleep study because that's what their buddy told them before they ETS or retire, they need one. They may come up with mild. And that's going to impact our treatment as well too, on what treating platforms we can give this patient. Moderate, now that's where they're really going to start to notice it, impacting their daily life. They don't have the same energy, right? And some of these symptoms will mask based off of like just life and going on in general, right? Takes naps. Who here has been depressed or hate their job? Where's all the Army guys, Air Force? Like, I love it. This is great. In the Army, there's a lot of people that hate their jobs. You get sent to a role you don't like. So it's very easy to be like, well, I just don't want to be here. So you're tired, you're kind of low energy. So kind of talk to your patients and say, hey, is this something environmental or are you truly sleepy? And then severe, these are the patients that are at significant risk for falling asleep while they're driving, or they frequently take naps, or they're just nodding off while they're talking to you. So this is what an actual sleep study will look like. It has a bunch of crap on here, blah, blah, blah. If you want to be that person, you can just go to impression and recommendations. I typically like to look at the study so I can talk to the patient. So the AHI was 74 an hour. Is that good or bad? Terrible. So what does that mean? That means 74 times in 1 hour they're waking up. So that's less than 1 minute of sleep at a time uninterrupted. So just put that in the context when that patient comes back and you think they're malingering or you're trying to get VA benefits or whatever. 74 means they're not even sleeping for a full minute a night. So we talked about severe could be AHI greater than 30 or the O2 sats. O2 desaturation was 71%. So is that below that 90%? Yeah. Patient spent 91 minutes without that. So is that greater than 20% of the study? Go up here, here's the actual time for the study, 3 hours and 33 minutes. So, what do we think? Yeah, that's well above 20%. I suck at math and I can figure that out, right? Then you go down here, they're going to give you that. So, severe OSA, and then they're going to talk about the treatment platforms, right? So, with severe OSA, that eliminates some of the treatment that we have available for this patient. So for all of them, it's going to be weight loss, avoidance of alcohol sedatives. For mild, we can do the oral, the mandibular advancement device, oral device. They're great for mild, but the patients are not very compliant with them, right? So the good thing about these on an Army or DoD sense is that you can deploy people easily. Pilots can be on them, and it's not going to affect their readiness or their ability to do their jobs. But people just are not very compliant with them because they're uncomfortable. And I'll show you some pictures of what they look like. Moderate to severe, the gold standard is going to be positive airway pressure. Bunch of different flavors. When this first came out, it was just CPAP. Then they went to BiPAP, bi-level positive airway pressure. Then they went to APAP, which is the most common now. So what it is basically you're going to get a ventilator class in pulmonary 2. But think about our baseline of our lungs. It's at 0, right? 0 pressure. So if I give you +5, it's enough to keep your alveoli inflated. Basically, that positive pressure is keeping those soft tissues from collapsing over the airway. So that's what positive airway pressure therapy is. It's just pushing airway pressure in there. They can still breathe normal, but it's keeping their airway open enough so that those soft tissues don't collapse over the actual trachea. So avoid supplemental O2 right here. Why do we think that? Think about like the critical thinking about what we talked about, hypoxic drives and all the other stuff. So if I knock up their hypoxia, or I knock up their oxygen saturation, they're never really going to get hypoxic, so they're not going to know to breathe necessarily. CO2 may not rise, but if the body's saying, hey, I'm good, I don't need to breathe any faster. So it can actually be detrimental to your patient if you give them supplemental oxygen and they don't need it. So here's an example of those oral devices. So you're going to have to send these off to dental or oral maxillofacial surgery to get these made. They're good for patients that can tolerate them for mild to moderate, right? So severe OSA, they're not going to get this. Just remember, oral devices, mild to moderate only. All right, so CPAP. I used to moonlight when I was enlisted doing CPAP, like home therapy setups. That was an eye-opening job because I would get sent to like a truck stop and I would be like a trucker behind a Waffle House. And I was like, this is going to go sideways right here. It's like lot lizards walking around. I don't know if you know what a lot lizard is. It's the prostitutes that hang out at truck stops. But I'm sitting there as a respiratory therapist with my little bag and stuff, setting it up. I got a pulse ox and like a stethoscope, and then I'm meeting some guy in his truck, and I'm meeting him in the back. I was like, this is just bizarre. If the cops come, I can't explain myself out of this. But they have battery-powered ones. They have ones that can plug into cigarette lighters, and they've gotten considerably smaller. They have travel CPAPs. But they are difficult, especially if you have the wrong mask. Some people are nose breathers, some people are mouth breathers, so they have a ton of different options. The reason I bring that up is compliance is the difficult portion with CPAP. Patients will wear it for an hour, then take it off in the middle of sleep, and not put it back on. They can't get comfortable. If they have facial hair, it's difficult to wear it. And again, some people will feel claustrophobic putting a full mask on. With all that being said, if your patients aren't using their CPAP, and you can easily tell, these are now, they have a memory card in there that when every time they go to follow up, they have to pull that card out of there and it gets plugged into their system so they can see if they're actually compliant with it. So they can't lie and say, yeah, I'm wearing my CPAP. I'm like, cool, bring it in here. And now they've even gotten smarter, is that these are Wi-Fi or Bluetooth, so they don't even need that memory chip so people can't like bring you their buddies, which I've seen before too as well. But there are options. Send them back to the respiratory therapy or sleep medicine clinic to get refitted. And they have 20 different options, and TRICARE is really good about covering all those different options for them. Surgery, UPPP, remember the Malin-Party score? So this would be like a 2 right here. I can't see complete back there. But what they do is they remove the tonsils, adenoids, uvula, and these soft tissues right here and sew it back up. So it's a very kind of drastic surgery. It's very not comfortable. Patients do not like it. And it doesn't have a very good success rate. It's like 50-50. Patients are going to benefit from this or not. But some patients, it just may be an anatomical thing. They've lost the weight. They can't wear the oral device. They can't wear CPAP. They may be a candidate for this. So this wouldn't be my first referral unless they just had a Malin-Party score of 4. I think that is going to be the cause. Otherwise, I'm going to try CPAP, try these other therapies, and this would be kind of a secondary option if they're not improving. Another one too, we talked about ENT is if they have a deviated septum, that may be the cause. They may be able to get surgery for that. Advancement surgery, this is very rare. Basically, their jaw, they offset it. Sometimes they'll fracture the jaw and actually pull it forward so that it doesn't collapse when they sleep. But it's very uncommon to have that surgery done. New hotness. Anybody seen the commercials for Inspire? Yeah, so it kind of looks like a pacemaker underneath the skin, but it's surgically implanted down here, and it has like a device that you put on top of it. You can control by your phone now. And it leads an electrode underneath the skin back here to the tongue. And it stimulates that so that it's basically staying constricted and up the entire time. It never relaxes. But this is still very, very expensive. You can only give it to like your severe patients. They have to fail CPAP and mean failures, like they've been back numerous times. So this is kind of like that last thing that anybody's going to pay for. I don't know yet if the DoD is doing it or if you can deploy afterwards because it's so new and it's very expensive. Potential complications of sleep apnea, right? Hypertension, again, if they have uncontrolled hypertension that's not responding to treatment, think OSA. MI, right, it's putting stress on their heart, their pulmonary vasculature, increases pulmonary hypertension, can lead to cardiac failure. CVA stroke, atrial fibrillation, again, that's why they have that ECG on the sleep study to show you if there's any cardiac changes. Chronic is sleep disturbances, memory problems. This is a big one for young to middle-aged men, right? That could be something, it'd be like, if you're gonna die, they're like, okay, well, if I die, I die. Like, hey man, your penis isn't gonna work either. Whoa, 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 whoa. Slow down, if I die, that's fine, but I wanna be a man. So find that trigger to get your patient motivated. Everybody has different triggers to see what matters to them. Then, you know, I've had to take people's driver's license away or suspend them, which you report up to the state, the Department of Transportation. If I know they have like severe sleep apnea and they're not using their CPAP, that's on you now as a provider. You can be held in court if you're not involving that. Same thing with like seizures. You're supposed to report that to Department of Transportation so they can't drive. Right, any questions about OSA or daytime hypoventilation? Yep. What do you mean?
You say you were diagnosed with it.
Good looking out, man. I appreciate that. So you got some brown stuff on your nose, but I appreciate you going. So what I was saying is about the mask is the number one thing. This right here, so this is a full face mask, right, which patients may not tolerate because it includes their mouth and their nose. They have nasal pillows that is just 2 little pillows that rest on your nose so your mouth is open. That may make you more compliant to the patient. They have low profile ones. They have ones that come above the head. So it's finding one that fits and works for that patient. I see the most common issues for CPAP failure is inappropriate sizing or inappropriate mask, right? So if you're a mouth breather and you put that nasal pillow on or just the nasal, what happens is you go to relax, go to sleep, your mouth opens and all that pressure literally just like a dragon. It comes to your nose and comes right out your mouth. So you have to figure out what mask works for them, right? So it's trial and error. Yep.
What about kids? What about peds?
Um,
They have small airways, harder, you know what I mean? Like,
yeah. I would say this is more so adult diagnosis. There are kids, right? I'm gonna be honest here for a second. Anybody ever watch 1,000-Pound Sisters?
Yeah.
I'm not gonna lie to you, man. I love that show. Where the fat one gets bit by a camel at a zoo, and then she gets arrested for marijuana when the paramedics show up. Like, you can't write that. It's amazing. But so obese patients like that, like the little kids, yeah.
Not obesity.
I would say it's very rare.
Tonsils and adenoids, you know what I mean? Like, just obstructive airways.
I mean, it's possible. I've never had one. I've never seen one. But I'm sure it's a possibility, right? If they're having that difficulty of sleeping, typically they're going to have other symptoms going on too that'll get them seen by ENT sooner than later. But I would say it's not very prevalent in kids. Any other questions? All right, so tomorrow I'll do a review with you guys. I'm going to put the review slides up tonight or this afternoon sometime when I finish them. So have them downloaded before tomorrow. For the review, if you ask me, is this going to be on the test, what am I going to tell you? Look like maybe. That's what I'm going to tell you each time, all right? So don't ask me, is this going to be on the test or not? Tomorrow I'll do your review. That's where we'll go over some practice questions. Tomorrow is the opportunity to ask me for clarification or differentiate them, or anything I say conflicts with slides, bring that up tomorrow. Please don't ask me if this is going to be on the test, because remove all those FYIs and just add it to the test. Any questions right now?